Good afternoon. My name is Dr. Jason Burnett, and I will be presenting for the next hour or so part 2 of the series titled Identifying and Intervening in Cases of Elder Abuse. And this section will focus mainly on screening and interventions. And this project is funded by a grant from the Health Resources and Services Administration of the Department of Health and Human Services. The grant was initially funded in 2007 with renewed funding for 5 years beginning in the year 2010. And the learning objectives for this presentation is to really help students determine the steps to screen for elder abuse, describe 3 interventions for victims of elder abuse, discuss 3 interventions for stressed caregivers, and list common community resources available to elders and their families. And so for the purposes of this presentation, we'll use elder abuse as a broad term that refers to the different forms, which include neglect, which includes self-neglect and caregiver neglect. Then there's emotional and psychological abuse, there's verbal abuse and threats, there's financial abuse and exploitation, there's sexual abuse and abandonment. So you might ask yourself, well, why should I identify cases of elder abuse? Well, one, we know that elder abuse is very, very common, and it's very harmful to the health, quality of life, and mortality of older adults. And the research shows that only 2% of physicians report elder abuse and neglect to Adult Protective Services, and this estimate varies across different states. But what we do know is that there's several very large organizations such as American Medical Association, American Academy of Family Physicians, American College of Obstetricians and Gynecologists, American Nurses Association, and the College of Emergency Physicians. They all recommend that physicians get involved in identifying, intervening, and reporting elder abuse. Now, the prevalence of elder abuse is roughly 11%, and this is based on the last national prevalence study conducted by Osierno et al., where they surveyed older adults across the country who are cognitively intact and asked them if they had been abused or neglected in the last 12 months. Now, the Joint Commission recognizes physician involvement as part of the protocol for identifying elder abuse in all ambulatory care settings. And intervention, especially using a disciplinary team, can be very effective, and there's lots of literature that's moving towards the discussion of elder abuse forensic centers and these different interdisciplinary approaches that have been shown to be effective. So how do we screen for elder abuse, especially in very busy primary care settings? Well, one way is to make the discussion or make the questions about elder abuse a routine part of the clinical practice. We also want to speak to our patients at eye level. And this is very important because what we do know is that older adults who have been abused often will not make eye contact, may seem very anxious. It's very important to be able to assess whether or not they will actually look at you directly, or it's also helpful to be on a eye-to-eye level with someone to let them know that you're there to help, you are their equal. And 3, you can keep questions simple, direct, and non-judgmental. And this is an important piece. It's okay to be direct with your questioning. You don't have to dance around the question of, have you been abused? It's often very effective to come out and ask that question very directly, but it's also important to keep it simple and be non-judgmental. And then you want to make sure that all the discussions that you have about elder abuse are private, because this is a very sensitive subject, and oftentimes older adults are reluctant to discuss it, and then they're often reluctant to have something done about it because it may put their caretaker or put their family at risk. But always remember, the primary focus is on patient safety, so this is a very, very important discussion to have with your patients. So as I mentioned earlier, elder persons usually will not admit to abuse or neglect unless probed, and therefore it's really important that we use a non-threatening manner to ask further questions about alleged abuse or potential abuse, and that includes trying to keep these patients comfortable. We want to assure their privacy during this discussion. We want to make sure that we attend to their hearing and vision needs, because just receiving a question of no could mean that they didn't understand the question or they didn't hear the question, but they're just giving you a response as compensation. So we want to make sure that we address these hearing and vision needs, and we want to demonstrate empathy, but we also want to be direct and honest with the patient, which will usually elicit more forthright responses. And we have to keep in mind that patient safety is paramount in intervention efforts. So what we may do is engage in safety planning, which is a process of the protector or helper and the victim jointly creating a plan to minimize victim risk, because, like I said, what we're mainly interested in is protecting the patient, keeping them from harm. And some of these plans may include prevention strategies, protection strategies, or notification strategies. These strategies, such as that are involved with prevention, may include relocating the older adult to a shelter, or moving the older adult, providing restraining or protective orders against a perpetrator. We may put in place some protection strategies, such as having escape routes, shelters, or having plans for moving the older adult away from the abuse whenever it's occurring by locking themselves away in an isolated room, and then using cell phones or some other means for getting a hold of emergency services so that they can come and assist the older adult in cases of elder abuse. So what are some of the screening questions we might ask in a busy clinical setting? Because there are many different tools that can be used in assessments and measures that have been developed for clinical settings, but some are not conducive to busy clinical settings. And the American Medical Association Diagnostic and Treatment Guidelines on Elder Abuse and Neglect provided a list of questions that are helpful for identifying or raising suspicion of elder abuse in the busy clinical setting. And so what question you might ask is, has anyone at home ever hurt you? Has anyone ever made you do things you do not want to do? Has anyone taken something that belongs to you without asking? Does anyone scold or threaten you recently or in the last few years? Have you ever signed documents you do not understand? Are you afraid of anyone that lives with or cares for you? Are you alone often? And has anyone ever failed to assist you with the help that you needed? As you can see, these cover physical abuse, financial exploitation, abandonment, caregiver neglect, and any positive response to these questions would likely raise the suspicion of the physician or of anyone asking these questions and lead to more direct questions to try to understand whether abuse is present or not. It is very acceptable to ask, have you been abused? And this goes back to that idea of being direct. Sometimes if you just ask an older adult, have you been abused? They'll respond with, they may say yes, or they may provide you an answer that makes you think, well, okay, let me probe a little further so that I can gain a good understanding of whether or not this abuse has occurred. So what are some best practices to follow as a physician? We want to be alert for unusual behavior, includes the possible abuse. So does the caregiver have little or no knowledge of the patient's medical conditions? As a formal caregiver, you would expect that this caregiver knows the medical conditions of the older adult, knows what medications they take, knows when they need to be taken to a physician, and understands the necessity for maintaining good personal hygiene, especially if they have conditions such as diabetes. And so if they do not know this information, it's likely that this person may not actually be there to provide them with care, and instead they're there to really take advantage of the older adult. And then, does the caregiver allow the physician to interview the patient alone? This is a big factor, because a lot of times caregivers will not want to be out of the presence of the older adult when they're being questioned, because it may allow that older adult to then speak freely about the caregiver and the abuse that's going on. So they often like to stay in the same room, and often they like to answer the questions for the older adult even when they're capable, or when the older adult is capable for providing these answers on their own. These caregivers will step in and start providing those answers, and if that occurs, it may be reasonable, actually is very reasonable, for the physician to ask the caregiver to leave the room and have that private discussion with the older adult. Then you might ask, has the patient changed to his or her caregiver? If they have a new caregiver that came in and you see some signs of potential caregiver neglect, you want to pursue that further to try to understand whether or not it's just a new situation where this caregiver is take on the care of this older adult and they just haven't been up to speed enough to provide them adequate care, or whether they're just not providing that care for some other reason. And then, are there frequent visits to the emergency room? This is an indicator of elder abuse for older adults, and it includes types of abuse such as physical abuse, financial exploitation, and caregiver neglect. These individuals who experience those are more likely to end up in the emergency room. And here's some other unusual behaviors. So if you have physical findings or discrepancies in labs and x-rays that differ from caregiver reports, this is usually a sign of abuse of some sort, because what they're trying to do is they're trying to cover up the fact that they've injured the older adult, and so they've blamed it on something else. The patient or the caregiver does a large amount of doctor shopping. If you see that your patient is going from this doctor to this doctor to this doctor, oftentimes it's a way to conceal the abuse by not allowing one physician to develop that relationship so that they can see a pattern of injury in this older adult. Now, does the caregiver have a mental or physical impairment? If this is the case, it could lead to caregiver neglect or some type of physical abuse, and that doesn't necessarily mean it's intentional, but it still could be there. Does the patient have unexplained or unusual injuries? And as we move along further in this presentation, we'll talk about some of those injuries and those injury patterns that are indicative of abuse, such as injuries to the head and torso and penetrating injuries that are more indicative of abuse compared to non-abused older adults. Okay, so relationships between the caregiver and the elder should be taken in context of ongoing relationships. That doesn't mean that when a case comes in and a caregiver who may be the husband of his wife and he may be the caregiver, and maybe they argue and maybe he yells a little bit and maybe she yells a little bit. Well, if that's been the ongoing relationship between this group or between these two people for their entire lives, it may not be considered abuse. So we have to take these things into the actual context. And the patients may also be reluctant to relate events. So either their fear of the caregiver or being removed, and we see oftentimes that older adults who are being abused, maybe they don't want to tell other individuals, especially law enforcement, that they're being abused, because caregivers are oftentimes family members and they don't want to get their family members in trouble. And then also, older adults who are being abused are oftentimes very worried about being removed from their home and placed in a nursing home. Even if that's not a high likelihood, they're still very scared of that. But if a patient is demented, the physician quite often has to rely on caregiver statements, which may or may not be true. So we have to think about whether these caregivers are actually providing us the right information, and look at these different labs and different x-rays and other physical findings that we see to try to correlate those with what the caregiver provides us as the reasoning for the types of injuries or disposition of the older adult. Now, some other signs of abuse may be that a patient's general appearance is slovenly, dirty, or disheveled. We see a lot of, with caregiver neglect, older adults will come in, even though they have primary caregiver, they'll come in with overgrown fingernails, their skin will be very dirty, their clothing may be dirty, or their hair may be disheveled. They look like they haven't had a shower in a while, and we see that also very commonly in our self-neglect population. A lot of these older adults will come in dehydrated. They may have low blood pressure despite having blood pressure medications. They may have very abnormal laboratory work such as lower albumin levels that may be indicative of malnutrition. They may have oral bruising, poor dentition, loose fitting or no dentures. And then there's trauma that may occur to the head and neck region, torso, that may be signs of abuse. Then there's burns on the skin, there's skin bruising in various stages of healing, lacerations, decubitus ulcers, signs of restraint use. And as I mentioned before, what we see in the literature is that these older adults who come in to our emergency rooms and come into clinics, those that have been actually abused often have injuries to the head, the neck, and the torso region rather than on the extremities. The extremity type injuries are indicative of accidents. Older adults who, they have a high risk of falling, so they may end up with fractured ribs, old fractures, splenic ruptures, hemorrhages. But what we also know from the literature is that there's a large number of older adults who come in with suspected falls, and it turns out to be that they've been pushed, and that's what actually led to the internal bleeding or the fractured ribs. So just because they come in and may be at risk of falls, there needs to be further examination to understand whether or not these are actually signs of abuse or signs of sort of a normal aging progression. Then there's impaired mental status that comes along with elder abuse. There's impaired function, ADLs and IDLs, depression, anxiety, mental illness. And this can be an outcome of abuse due to reduced psychological and physiological reserves of older adults. So a small insult, such as yelling at an older adult or isolating them from their family, may lead to a cascade of events that lead them to kind of spiral in a negative way, so that they're often chronic, multiple comorbid conditions may be exacerbated and lead to poor quality of life and even possibly mortality. This may lead to unusual or impaired gait or evidence of old untreated fractures. So some of the intervention strategies. Let's start with a patient diagnosed with dementia and having behavioral problems. So what we'd want to do is we'd want to rule out other medical conditions first, because remember what we're trying to do is intervene on the abuse. We want to reduce the abuse, but first we have to understand, what are the causes or other potential causes of the abuse. So like I said, we'll rule out other medical conditions. We may request psychiatric evaluation and possible medication, maintain the continuity of care, repeatedly orient the patient to his or her surroundings, request referral for home services, respite care, or possible institutional placement, and assess patient's capacity. These are all very important things that can be done in order for us to understand what interventions other than these can be done to improve the outcomes of these older adults. Now, what about a caregiver abuse of a patient with dementia? Well, we may want to provide a referral for respite services, want to provide a referral for counseling or domestic services. And this referral for respite services, it depends on the reason for the abuse. Maybe this caregiver is having caregiver burnout, or they're really stressed out, having financial troubles that's causing them stress, which then they lead to having hard times with the patient, and therefore they end up abusing them. And so providing these respite services may take some of that burden off of the caregiver and possibly reduce that type of abuse. We may be able to provide information on social service agencies or support groups that could help. If we have a caregiver who's abusing an older adult, and if it is not necessarily intentional and it's more associated with burnout, maybe Adult Protective Services can come in, provide some sort of help that could take some of that burden off the caregiver. We could recommend the placement of a family member if indicated, and when possible we could encourage social and or religious support, because a lot of times having older adults continue to do things they've done all their life helps reduce some of that potential for abuse, because it helps the older adult gain that social support that they need to have that scrutiny to where they're not living in an isolated situation, and plus because they're able to get out and do things that they enjoy doing, that oftentimes alleviates some depression that then could be feeding back into their actions against the caregiver, which then could lead back to elder abuse. And then what if we have a mentally ill patient who assaults his or her parents? Well, we might want to provide a psychiatric referral for the abuser, suggest mental health counseling for the victim, or suggest alternative living arrangements. Then we have patients with decisional capacity who are refusing treatment. Well, in that case, if we have an older adult who does have decision-making capacity, and especially medical decision-making capacity, then what we would do is we'd contact Adult Protective Services. We may educate the patient about possible dangers for making certain situations that puts them at risk. We may provide emergency contact numbers, follow up, and then develop a safety plan for these individuals. Because a lot of them, the reason why they do not want people to come into their homes is because they're afraid of disrupting that normal continuity of life. And if we can go in and be non-threatening and develop safety plans for them and give them the information they need to stay safe, maybe that'll be enough to eliminate the potential for harm. And then what if we have an elder abuse patient without the capacity for decision making? Well, once again, we call Adult Protective Services. We may assist agencies with guardianship or conservatorship recommendations and provide referrals and resources for financial management, because these individuals, if they do not have the financial or medical decision-making capacity, they need someone that can step in and do that for them, but in a way that does not put them at risk for elder abuse. Okay, so reporting abuse, what is the physician's role? Well, in most states, and when I say most, I mean all but 6 states have mandatory reporting laws for elder abuse. And so physicians are mandatory reporters just like everyone else. And these laws vary on the penalties for not reporting, the age of the person covered under the reporting requirements, the classification of the abuse as criminal or civil, and investigative procedures and remedies. Okay, and physicians should at very least be familiar with the criteria for reporting in their state, because it's very important that we make these referrals and these reports, because physicians are sitting in a really good position to detect elder abuse in their clinical older adult patients, because they have developed these long-lasting relationships with them. Now, what are some of the barriers to physician reporting? Well, there's disparities in definitions. There's different regulatory requirements. There's these fears of actually doing more harm to their patient. And what we've seen in the literature is that when a physician screens, and if they have a raised suspicion of elder abuse, they should actually refer that to Adult Protective Services, because even if Adult Protective Services goes out into that home and investigate elder abuse in the older adult, and they do not substantiate it, it does minimal harm to that older adult, and at least we've taken the steps to possibly reduce or prevent elder abuse in the population. But there's also some other reasons why physicians may not report. Well, there's a lack of physician training in elder abuse. And if we look across all the medical schools in the United States, only 10% require any form of geriatric type training, which elder abuse falls into. And then, we also know that among those who have been trained specifically to detect elder abuse, they still have trouble recognizing elder abuse, because it's a very complex problem, and when they come into a busy clinical setting, it's not very easy to detect. So if someone does detect elder abuse, what do? Well, there's an organization called Adult Protective Services, and what Adult Protective Services is, this is an organization, a state organization that was developed in 1975 as part of the Social Security Act to provide services to individuals 18 years to 64 years with a disability, individuals 65 and older who live in domestic settings who have been abused. And so Adult Protective Services ensures the safety and well-being of elders and adults with disabilities who are in danger of being mistreated or neglected, are unable to take care of themselves or protect themselves from harm, and have no one to assist them. So in these cases, if someone does identify elder abuse, they'll make a referral to Adult Protective Services, and Adult Protective Services will then go out into the home and they will perform very comprehensive assessments of the individuals. And the APS interventions follow a procedure where they receive reports of elder and vulnerable abuse, neglect, or exploitation, and then they do an investigation on the report. They assess the victim's risk, and they use different measures to do this. For instance, here in the state of Texas, we have a 57-item risk assessment scale that they go out and they review in the person's home, which asks 57 different items on the risk across medical, social, mental health, and environmental domains. They assess the victim's capacity to understand his or her risk and ability to give informed consent. They develop a case plan. They arrange for emergency shelter, medical care, legal assistance, and supportive services, and they arrange for evaluations. So what are some of the limitations of Adult Protective Services? Well, APS clients' wishes and interest supersedes the wishes and interest of family and the community, because we try to maintain a sense of autonomy for individuals in society. So if people have the right to decline services even when they're putting themselves in harm's way, if in fact that person has the decisional making capacity. Another limitation is the plan to manage the case must maximize self-determination of the individual. A client has the right to live in unsafe surroundings or engage in unsafe behaviors, and this goes back to that ability to make those decisions. And once again, a client has a right to refuse services and/or treatment unless life is threatened or he or she has no mental capacity available, and this includes their medical decision-making capacity. So even when Adult Protective Services gets involved, what we know is that interdisciplinary approaches are the best approaches for intervening in these cases of elder abuse. And so physicians may take an interdisciplinary team approach using formal and informal relationships with a group of individuals such as the physician. They may have nursing involved, adult protective services, social workers, law enforcement, elder law attorneys, and then others such as nutritionists, psychiatrists, psychologists, social service agencies, faith-based groups, advocacy groups. Any combination of these may be utilized on any given case for elder abuse, because these are often complex cases that don't necessarily represent the same way across cases, and therefore may require different combinations of these groups to intervene. And here's a model of an interdisciplinary team approach, and this is the Texas Elder Abuse Mistreatment Institute. And it's a collaboration between the University of Texas Health Science Center in Houston Medical School and the Texas Department of Family and Protective Services. Now, this group consists of nurse practitioners, service caseworkers, law enforcement, elder law attorneys, district attorneys, Better Business Bureau. We have physicians, and the history of this group is that it started in 1995 as a discussion between Adult Protective Services and geriatric physicians here in Houston. What developed out of this was the fact that Texas Adult Protective Services, they have a lot of elder abuse cases that involve exacerbated medical conditions or comorbid medical conditions that need to be evaluated and need to be treated before they can get the individual to a state where they can make a decision as far as a care plan to benefit the older adult and reduce the risk of further elder abuse. And so this group got together and in 1997 formally became the Texas Elder Abuse and Mistreatment Institute. And so what is the team approach? Well, the client is referred by APS or other parties for physical and their capacity assessment. And then we have a group of clinicians that conduct a comprehensive geriatric assessment and assess capacity if needed. And that includes medical decision-making capacity. And then once this comprehensive geriatric assessment has been completed along with a capacity assessment if needed, then an interdisciplinary team will meet and discuss the case. And that interdisciplinary team will include the physician who assessed the older adult. They'll include the APS caseworkers and anybody else that was involved in this interdisciplinary approach. They'll discuss this case and then come up with a formal care plan for the abused older adult. And this care plan will be implemented and followed up as necessary. So where and how do we report? In most states, a person who knows or suspects elder abuse is required to report the abuse. Now, as we mentioned previously, there's 6 states that do not require this, but it's good practice for anyone in any state make a report of elder abuse even if it's not required. And there's a couple of different ways where someone can make a report. They can use an 800 number. It'd have to go to their individual state to find that 800 number and then call that number and make an anonymous report, or they can make a report online by sending an email to the appropriate agency. So let's go through a case study here. On the next few screens, you'll be presented with a case. Consider the patient and the caregiver and their needs as you review the content. After you've given the patient's presentation, you will find images on the top of the screen. Click through them to learn more, or just click the button at the bottom of each screen to go through the case. So here's the patient presentation. We have Mary Jones is an 80-year-old female living with her single working daughter. She uses a walker for mobility and needs assistance with grooming and dressing, but she can toilet and feed herself. Her daughter reports that Mary is irritable, has been falling more often, is becoming obstinate. Mary has lost 15 pounds in the last 2 months. She does not currently take any medications. There's indication of bruising on her forearms, left hip, a small bruise on her forehead, numerous abrasions on her arms and legs, and she complains of pain in her left forearm. Mary's daughter was irritable. While with Mary at her medical appointment, she was impatient with Mary, belittling Mary, and speaking sharply with a raised voice. So let's consider a few questions. Thinking about Mary's case, how would you answer these questions? Is this abuse or neglect? Is Mary's daughter's behavior consistent with caregiver stress? What are some alternatives for Mary and her daughter? And should the physician make a referral to Adult Protective Services? Well, what we might want to do is first look at the findings from the comprehensive geriatric assessment. Remember, we want to rule out medical causes first. So we may look at the lab work, rule out malnutrition, dehydration, some form of cancer or other illnesses. We may want to do X-rays of the left arm, do the confusion assessment method to rule out delirium. We may want to do a medication review. Separate interviews with Mary and her daughter, because remember, these are important issues. If we want to determine whether abuse is there, we want to do this in private and separate from each other as far as the interviews. And then screening examinations for possible dementia and/or depression. So if we did all that, what did we find? Well, labs were essentially normal. Mary was moderately demented. The left forearm was negative for fracture, and there was no indication of delirium. The physician ascertained that the daughter had recent medical problems but continued to work and care for Mary. She was also having financial difficulties. So based on what you've seen so far, what might be your recommendations? Well, in this case, the physician recommended in-home services with respite care. Nutritional supplements were ordered for Mary. A report was made to Adult Protective Services. And another appointment was scheduled in 2 weeks, and the nurse was asked to follow up with Mary by phone within 1 week. So is this a case of abuse? Considering all that you have learned about Mary and her case, is this case abuse or not? It's possible abuse. Physician recognized that Mary's daughter was under extreme pressure, a risk factor for elder abuse. He referred Mary to APS for determination of abuse, but also to provide Mary's daughter access to resources and services to keep Mary safe. Now, physicians are often fearful that the patient-doctor relationship could be compromised if they question whether abuse exists, but physicians can put the need to refer in the context of assisting with referrals and needed services for the patients and the caregiver. So what that means is that if there's suspicion of abuse by a caregiver or by a physician, and a physician is worried about whether or not asking that question could put that relationship between the physician and the patient in jeopardy, which could then lead to even more harm for the patient, it can be provided in the context of the reason why you're asking this question is to further assist and improve outcomes for the older adult. Okay, so in conclusion, physicians and other clinicians will see cases of elder abuse in their practice. It's very common for those cases to come into a busy clinical setting, but it's also very common for these cases to go undetected. That's why it's important to know how to recognize the problems and to screen for abuse. And there are documents that to assess for and to make appropriate referrals for care. The steps taken in the clinic can make a significant impact on the life of an older adult, and so it's very important that we make screening for abuse in clinic settings routine, and we follow certain procedures so that we can pick up on it, and if we see even the slightest suspicion of abuse, it's okay to make that referral because we know that it doesn't do any undue harm for that older adult in the long run.